You're standing at the nurse's station, right? You've got a lukewarm cup of coffee in your hand, and the night shift nurse is running through morning report.
Oh, yeah. The classic start to the shift.
Exactly. And they just rattle off a diagnosis like stage 4 adenocarcinoma. And that is immediately followed by this massive laundry list of systemic treatments like monoclonal antibodies and cytotoxic drugs that you can honestly barely pronounce, let alone spell without looking them up in the drug guide.
Right. And then they casually mention the patient has a central line. They are on strict neutropenic precautions. They're scheduled for concurrent radiation therapy this afternoon.
Which is so much to coordinate.
It is. And to top it all completely off, they've been spiking a low-grade fever since 0400.
It's the exact moment your heart just drops into your stomach. You know, you look down the hallway at room 412, you look back at your chicken scratch notes, and this massive wave of overwhelm hits you.
Oh, I've been there so many times. The stakes just feel incredibly high. I mean, the medications are notoriously toxic.
Yeah.
And you're suddenly standing there wondering how you're supposed to safely prioritize care without missing some critical, life-threatening, subtle change.
Exactly. It feels like you need to be an oncologist, a pharmacologist, and like a seasoned therapist just to walk into the room safely.
Yeah.
And that is exactly why we are here today. Welcome to an episode of the Super Nurse Podcast, created by Brooke Wallace.
Yes. Okay.
For anyone new to our clinical community, Brooke is a 20-year ICU nurse, an organ transplant coordinator, a clinical instructor, and a published author who has literally spent her entire career translating complex medical science into bedside survival schools.
And we want to be incredibly clear right out of the gate here. We are not Brooke.
We are definitely not. But, you know, we have the absolute privilege of utilizing her bedside knowledge, her meticulously detailed clinical notes, and her signature teaching style.
Right. Our goal is to help you, whether you're a nursing student who is currently drowning in textbook chapters, or maybe a new grad trying to survive your first oncology rotation.
Which is intense.
So intense. We want to help you bridge that massive, intimidating gap between the academic theory and real, practical patient care.
Our mission for this episode is highly specific. We are going to completely demystify cancer. We're stripping away all the confusing jargon, breaking down the treatments by their actual biological mechanisms, and showing you exactly what clues to look for at the bedside.
Because we want you to understand the why behind every single intervention, so that when you walk into room 412, you aren't just reacting. You know, you are thinking critically and you are acting confidently.
By the time we wrap up today, those multisyllabic chemo drugs and overwhelming care plans are going to make perfect logical sense. Because once you understand how the disease actually operates, the nursing interventions just click into place.
They really do. It becomes a puzzle you know how to solve.
Exactly. Oh, and before we dive into the pathophysiology, I want to invite you to subscribe to this channel. Also, make sure you go watch the comic book-based video version of this exact content on YouTube.
Oh, it's so good.
It really is. You can find it on our channel, Super Nurse Comics. The link is right down in the description. It is an incredible visual tool that takes these invisible cellular processes and just makes them unforgettable.
Those visuals are a total game changer. But let's start laying the foundation right now. We need to talk about the rogue cell.
Right.
In nursing school, you're taught the textbook phases of cancer, right? Like initiation, promotion, and progression.
The classic trio.
Yeah, but we need to translate that pathophysiology into plain English. Like what is actually happening inside the patient's body?
Let's unpack that, because to understand the pathology of cancer, you first have to understand the baseline of normal human biology. We know the body is made up of trillions of cells, and normally these cells operate under a strict, highly regulated set of social rules, like they grow when they are told to grow, they divide to replace old or damaged tissue, and critically, when they become damaged or obsolete, they undergo apoptosis.
Yes, apoptosis is the cornerstone of cellular health. It is programmed cellular death.
Which sounds bad, but it's actually essential.
It is. It's not some messy inflammatory process. It's a neat, orderly dismantling of the cell. You see, a normal cell has internal checkpoints, kind of like quality control inspectors on a factory line.
Oh, I like that analogy.
Right. So if the cell's DNA is damaged beyond repair, the cell essentially recognizes its own defect. It realizes it's a danger to the surrounding tissue and it self-destructs.
It takes itself out for the greater good.
Exactly. Cancer, fundamentally, is what happens when that specific orderly quality control process completely breaks down, and it always begins with DNA damage.
Okay, so the DNA gets damaged, the quality control inspectors basically fall asleep on the job, and suddenly that polite rule-following cell turns into this rogue, immortal entity that just refuses to die.
Right.
In clinical experience, I've always loved using a car analogy to explain this initiation phase because it perfectly illustrates the genetic breakdown we see at the bedside.
The car analogy is the best. Walk us through it.
So think of a cell's growth cycle like driving a car. You have an oncogene. Normally, this acts like the gas pedal, telling the cell when to divide and grow. And then you have a tumor suppressor gene, the most famous one being the p53 gene. That acts like the brake pedal, telling the cell to slow down, stop dividing, or undergo apoptosis if the DNA is corrupted.
It's a brilliant analogy because it highlights that cancer isn't just one single thing going wrong. It's a dual failure.
Right.
In the initiation phase, a genetic mutation occurs that essentially jams the oncogene, the gas pedal, all the way to the floor. The cell is receiving a constant screaming signal to divide.
Just flooring it.
Flooring it. But normally, the body could handle that if the brakes worked right. The problem is the exact same mutational process has completely shattered the tumor suppressor gene. The brakes are gone.
Wow.
So you have a cellular vehicle accelerating out of control with absolutely no way to stop. That is initiation.
Okay, so the car is speeding with no brakes. But it doesn't just instantly become a massive tumor overnight, right?
No, it doesn't.
And that brings us to the promotion phase. This is where these mutated, speeding cells are exposed to promoters. These are factors in the body or the environment that actively encourage that rogue growth.
Yeah, they egg it on.
Exactly. I always think of certain hormones here. For example, estrogen can act as a massive promoter for certain types of breast cancer, acting like high-octane fuel for that speeding car.
Precisely. The promoter doesn't cause the initial mutation itself, but it creates the perfect fertile environment for the mutated cell to thrive and multiply.
And then we cross the threshold into progression.
Yeah, this is where it gets truly dangerous. The tumor cells acquire even more mutations. They grow faster, they lose their specialized features, a process called undifferentiation, and they gain the ability to invade surrounding tissues.
I want to pause here for a second and really dig into the why of this progression because the mechanisms are just fascinating. These rogue cells don't just passively sit there and grow in a clump.
No, they are aggressive and they are incredibly manipulative.
Exactly. One of the wildest things clinical experience shows us is how they handle the immune system. A normal, healthy immune system, specifically your cytotoxic T cells and natural killer cells, should look at this mutating tumor, recognize it as a foreign threat, and eradicate it.
That's their whole job.
Right. But cancer cells evolve to send out chemical signals that essentially drug the immune system.
It's a localized form of immunosuppression. They can express specific proteins on their surface that act like a fake ID.
A fake ID.
Yeah. When the immune cell comes by to inspect the cancer cell, it sees this protein, assumes the cell is a normal, healthy part of the body, and just moves on. They literally put the body's natural defense mechanism to sleep.
It's like a bank robber standing inside the vault.
Right.
And when the security guard walks in, the robber just flashes a fake badge, and the guard says, "Oh, sorry to bother you, have a good night," and holds the door open.
That is exactly what happens on a cellular level. It's wild. And the manipulation goes even further when we look at the tumor's metabolic needs.
Because they're growing so fast.
Right. Because these cancer cells are dividing so rapidly, their metabolic demand is astronomical. They need massive amounts of oxygen and glucose. Now, a tiny cluster of cells, maybe a millimeter across, can survive by just diffusing nutrients from the surrounding tissue. But once it grows beyond that, it runs out of food. It needs its own plumbing.
So what does it do? It builds its own pipelines.
Yes. The tumor starts releasing chemical signals, primarily one called vascular endothelial growth factor, or VEGF.
Right, VEG.
This triggers a process called angiogenesis. Angio meaning blood vessel and genesis meaning creation. The tumor literally forces the host's body to sprout new custom blood vessels that route directly into the tumor mass.
It just hijacks the host's biology.
It completely hijacks the body's vascular network to siphon off the blood supply. And that allows the tumor to hog all the nutrients meant for healthy tissues.
All right, this is the perfect moment to pull all of this biological theory directly to the bedside.
Let's do it.
We have this rogue manipulative tumor. It's putting the immune system to sleep, and it's building its own custom blood supply to siphon off the body's glucose and nutrients. nutrients. What does this actually look like to the nurse who is assessing the patient?
That's the key question.
Right. What is the clinical logic we need to apply? Because we aren't looking at VEGF molecules under a microscope in a patient's room. We're looking at the human being in the bed.
Connecting the pathophysiology to the physical assessment is the hallmark of a great nurse. Because cancer cells are huge metabolic drains, because that angiogenesis is actively stealing nutrients to fuel their rapid growth, one of the absolute biggest red flags you will see in practice is unexplained weight loss.
Yes.
The evidence tells us that if a patient comes into the clinic and says, I've lost 20 pounds in the last 2 months, and I haven't changed my diet, I haven't been exercising, the weight is just melting off, your clinical alarm bell should be ringing at maximum volume.
Yes, because of that weight loss is the outward physical symptom of that internal vascular hijacking. The tumor is essentially starving the rest of the body to feed itself.
Exactly.
It's a condition called cachexia, where muscle and fat are just wasted away. What are some of the other key bedside red flags that clinical experience trains us to look for?
Well, we're looking for changes that disrupt the normal baseline function of the body's systems. For instance, a sudden and profound change in bowel or bladder habits. If you have a patient who has been regular their entire life, and suddenly they are dealing with severe alternating constipation and diarrhea, or they report blood in their stool, that is a massive red flag.
Definitely.
We look for difficulty swallowing or a sensation that food is constantly getting stuck in the esophagus. We assess for changes in a wart or a mole-like, the classic asymmetric, multicolored, evolving lesion that is highly characteristic of melanoma.
The ABCDEs of melanoma.
Exactly. But overarching all of these specific signs is one incredibly important concept. There's a word that you'll hear repeatedly in oncology nursing, and that word is persistent.
Persistent.
A persistent cough, persistent hoarseness, a persistent low-grade fever, persistent indigestion.
I'm so glad you highlighted the word persistent, because in nursing, persistent isn't just an adjective. It is a critical diagnostic clue. It changes how we view the symptom entirely.
Absolutely. Think about what persistent means in the context of clinical judgment. It means that standard evidence-based interventions are failing.
Right, the usual fixes aren't working.
Let's say a patient comes in with a hacking cough. We assume it's a bacterial respiratory infection, so we prescribe a course of antibiotics and some cough suppressants. But a month goes by and the patient returns.
And they're still coughing.
The cough is still there. In fact, it's worse. That persistence tells the nurse that our initial hypothesis was wrong. We are not treating the root cause.
Yeah.
The surface level explanation has failed, which means something much deeper and more structural, perhaps a growing tumor pressing against the bronchial airway, is causing the reflex. You must always escalate persistent symptoms.
That is the kind of critical thinking that saves lives. Okay, so we have a really solid grasp on how these rogue cells operate on a cellular level and how they manifest as symptoms at the bedside. But when you get report, or when you open a patient's chart, you are going to be hit with a wall of terminology classifying the disease. We need to understand the cancer roster so we actually know what kind of biological warfare we are dealing with.
Right. Because if you look at it from a histological standpoint, which just means looking at what specific type of tissue the cancer originated in, there are well over 100 different types of cancer.
Which is overwhelming for a student.
It is. But they generally fall into a few major categories that nurses must instantly recognize. The most common category by far, accounting for 80 to 90% of all human cancers, is carcinoma.
That is a staggering majority. Why is carcinoma, out of all the possible cellular mutations, so incredibly common?
It all comes down to the environment and the behavior of the tissue of origin. Carcinomas originate in epithelial tissue.
Okay.
Epithelial tissues are the linings of your body. They form your outer barrier, your skin, and they line your internal organs and passageways, like your lungs, the ducts of your breast tissue, your gastrointestinal tract, and your bladder.
Oh, that makes perfect biological sense. Epithelial tissues are the frontline defenders.
Exactly.
They are the tissues that are constantly interacting with the outside world and taking the brunt of external irritants. Like, your skin is constantly bombarded by UV radiation.
Your lung lining is constantly exposed to inhaled toxins, pollutants, or cigarette smoke. Your GI tract is constantly processing whatever chemicals or irritants you ingest.
Yeah, they take a beating.
Plus, because they are barrier tissues that take a lot of wear and tear, epithelial cells naturally have a very high rate of turnover. They are constantly dividing to replace dead cells.
You nailed it. Higher division rates mean more chances for a DNA replication error to occur.
Right.
Couple that natural risk with constant exposure to environmental carcinogens, and you have a recipe for mutation. That is the clinical logic behind why carcinomas dominate.
Okay, so that's the why.
So when you see a diagnosis like adenocarcinoma, which refers to a cancer of glandular epithelial tissue like the prostate or the breast, or squamous cell carcinoma, which often affects the skin, the mouth, or the lining of the esophagus, you immediately know you are dealing with a cancer of the linings.
Good to know. The next major category to know is sarcoma. Sarcomas originate in mesenchymal tissue, which is your connective and supportive tissue. We're talking about bone, cartilage, fat, muscle, and blood vessels.
And these are much rarer, right?
Very rare. Sarcomas make up only about 1% of adult cancers, but they are notorious for being highly aggressive. Think osteosarcoma in the bone or liposarcoma in the fat tissue.
Yeah.
Because they occur in the deep structural tissues, they often grow quite large before they cause noticeable symptoms.
And then beyond the tissue type, we have the broad clinical distinction between solid tumors and liquid tumors. Carcinomas and sarcomas obviously form solid masses, but what about the liquid side?
Liquid tumors is a colloquial term for cancers of the blood and the immune system, though it's worth noting that lymphomas can actually form solid masses in the lymph nodes. But generally, we are talking about leukemias, lymphomas, and myelomas. Leukemias originate in the blood-forming tissue, the bone marrow. Instead of forming a localized lump, the bone marrow starts churning out millions of abnormal, non-functional white blood cells that flood right into the bloodstream.
They just take over the circulation.
Exactly. Lymphomas and myelomas begin in the cells of the immune and lymphatic system. The systemic nature of these liquid cancers changes the treatment approach entirely, which we will get to.
Okay, so we know the tissue it started in. The next crucial piece of information in the chart is the staging.
Right, the staging.
It's usually a cryptic combination of letters and numbers, specifically the TNM system. Let's translate the TNM system into plain English, because a nurse has to know how to read this to anticipate the patient's complications.
The TNM system is the gold standard international system for staging solid tumors. It paints a precise picture for the healthcare team of exactly how extensive the cancer is. And that staging dictates everything about the treatment plan.
So what's the T?
The T stands for tumor. Specifically, the size and the extent of the main primary tumor. It typically ranges from T1 to T4.
Okay.
A T1 is a small tumor that is well contained within its original layer of tissue. A T4 is a large, bulky tumor that is broken through its boundaries and physically invaded deeply into adjacent organs or structures.
So applying bedside logic here, if I am assigned a patient and I see a T4 colon cancer in their chart, I am immediately putting on my critical thinking hat regarding mechanical complications.
Exactly.
Because a T4 means that tumor is huge and invasive. I'm going to be hypervigilant in my physical assessment for signs of a bowel obstruction like absent iole sounds, severe cramping, or rigid abdomen, because that massive tumor is physically blocking the plumbing.
That is proactive nursing. You're anticipating the complication before it happens. The next letter is N, which stands for nodes specifically, regional lymph node involvement.
Like the local filters?
Right. Are there cancer cells in the lymph nodes immediately surrounding the primary tumor? This is graded from N0, meaning the nodes are clean, up to N1, N2, or N3, depending on the number of nodes involved in their location.
I have a mechanical question about this process.
Sure.
If a cancer spreads to the lymph nodes, is that essentially the cancer finding an on-ramp to the body's interstate highway system?
That is a phenomenal visualization. Yes, the lymphatic system is exactly like a highway. Earlier, we talked about how normal cells are well behaved.
Right.
Part of that behavior is cellular adhesion. Normal cells produce proteins, like E-cadherin, that act like molecular Velcro, giving them stuck tightly to their neighbors.
They stay where they belong.
Exactly. As cancer cells mutate and progress, they often stop producing those adhesion molecules. They literally become less sticky. This allows individual cancer cells to break off from the main primary tumor.
They unvelcro themselves.
Exactly. The lymphatic system is a vast network of vessels running throughout your entire body, designed to drain excess fluid from your tissues. If one of those unvelcroed cancer cells slips into a lymphatic vessel, it gets swept right into the current.
Wow.
It travels along this highway until it hits a lymph node. Lymph nodes are designed to act as biological filters, trapping debris and pathogens. The cancer cell gets caught in the filter and starts to multiply.
And then what?
Well, if a surgeon removes those regional nodes and the pathologist finds cancer in them, it is a pivotal moment in the diagnosis. It proves definitively that the cancer has acquired the necessary mutations to travel. The local problem is beginning to become a systemic threat.
Which perfectly explains the final letter, M.
Yes, M stands for metastasis. This indicates the distant spread of the cancer to other organs. M0 means the cancer has not spread to distant sites. M1 means it has.
Okay, M0 is local, M1 is distant spread.
Right. And the pathophysiology here is crucial. If a patient has breast cancer and those cells travel through the lymphatic or circulatory highway and take up residence in the bones or the brain, that is an M1 stage.
Right.
But we must be precise with our language with patients. Breast cancer that has metastasized to the brain is not brain cancer.
Oh, that's a huge point to make.
It's a metastatic breast cancer.
Yeah.
If you look at those tumors in the brain under a microscope, the cells look and behave like breast tissue cells, and they will respond to breast cancer treatments, not brain cancer treatments.
That is such a common misconception. So pulling it all together, if I see T1, N0, M0, I know I'm looking at a small, highly localized cancer with an excellent prognosis, likely treatable with just a targeted surgery.
Exactly.
But if I see T4 and 2, M1, I'm looking at an advanced, systemic, metastatic disease. The goals of care, the treatments, and the side effects I'm going to manage at the bedside are going to be vastly different.
Vastly different.
Now, alongside this staging, we frequently draw blood for tumor markers. Can you explain the mechanism of what these markers are, and more importantly, how we use clinical judgment to interpret them?
Sure. Tumor markers are biomarkers, usually specific proteins or hormones, that are produced either directly by the cancer cells themselves or by the patient's body in response to the presence of the cancer.
Okay.
They can be detected in blood, urine, or tissue samples. A classic example that clinical experience shows us is vital to know is CEA, or carcinoembryonic antigen, which is heavily associated with gastrointestinal cancers, specifically colon cancer.
But there's a trap here for new nurses, right? We don't just draw a single CEA level, see that it's elevated, and definitively diagnose a patient with colon cancer.
You absolutely do not. Tumor markers are rarely used as primary diagnostic tools in isolation.
Why not?
The reason is that they lack perfect specificity. Heavy smoking, inflammatory bowel disease, or even certain benign liver conditions can cause a CEA level to elevate.
Ah, so it could be a false alarm.
Right. The true clinical value of tumor markers, the real bedside logic, comes into play with monitoring the trend of the marker over time, specifically to evaluate the effectiveness of a treatment.
Walk me through a clinical scenario of how that looks over time.
Let's say a patient is diagnosed with colon cancer via colonoscopy and biopsy. Before they go into surgery, we draw a baseline CEA, and it is highly elevated. The surgeon goes in and successfully resects the tumor.
Okay, tumor's out.
A few weeks later, we draw the CEA again, and the level has plummeted back down to a normal baseline. As the nurse managing this patient in outpatient follow-up over the next 2 years, you are going to draw that CEA every few months.
Right, checking in.
You want to see a flat line. Consistently low levels mean the surgery removed the source and the cancer has not returned.
But if I'm reviewing their flow sheet and I notice that 6 months ago the CEA was 2, 3 months ago it was 5, and today it's 12.
Then your clinical alarm bells go off. A steadily rising tumor marker is an incredibly sensitive early warning system. It strongly suggests that microscopic cancer cells were left behind, or that the cancer has metastasized and is beginning to grow again.
That's terrifying.
It is. But this biochemical recurrence often happens months before a new tumor would even be large enough to be visible on a CT or PE scan. It allows the oncology team to pivot and initiate a new systemic treatment plan early.
Okay, this structure is coming together beautifully. We understand the rogue cell's mechanics, we know how to classify it, and we know how to stage the battlefield.
Yes, the groundwork is laid.
Now, it is time to plan the counterattack. Let's transition to the arsenal we use against cancer. And we have to clearly differentiate between local treatments and systemic treatments, because as a bedside nurse, if you don't know what kind of warfare the body is experiencing, you cannot possibly anticipate the side effects.
Absolutely. The treatment modalities broadly fall into those two distinct categories. Local therapies are exactly what they sound like. They are designed to eradicate a tumor at a specific, localized anatomical site without causing significant physiological impact to the rest of the body.
What are the main ones?
The two primary pillars of local treatment are surgical resection, physically cutting the tumor, and a margin of healthy tissue out of the body, and radiation therapy, which uses targeted high-energy beams to irreparably shatter the DNA of the cancer cells in one very specific zip code.
So if a patient is receiving radiation solely to their left breast for a localized carcinoma, they are not going to experience systemic hair loss on their head. The collateral damage is localized to the battlefield.
Correct. The side effects are confined to the anatomical path of the radiation beam. But as we discussed with the T&M staging, cancer is insidious.
Yeah, those unvelcroed cells.
Exactly. It often micrometastasizes. A few rogue cells might have already unvelcroed and hopped on the lymphatic highway before the surgeon even made the first incision. You can't surgically remove something you can't see.
Right.
That is why we rely heavily on systemic treatments. Systemic therapies are introduced into the bloodstream and travel throughout the entire body to seek out and destroy cancer cells wherever they might be hiding.
And the most historically famous systemic treatment is traditional chemotherapy, which we are going to tear apart and analyze in a few minutes because of its immense toxicity.
Oh, we definitely are.
But oncology has evolved rapidly. There are newer systemic treatments that patients will ask about, specifically targeted therapies and immunotherapy. How do the mechanisms of these newer drugs differ from traditional chemo?
Well, traditional chemotherapy is essentially a systemic poison. It is a blunt instrument that targets any cell in the body that happens to be dividing quickly.
It's indiscriminate.
Totally indiscriminate. Doesn't care if it's a cancer cell or a healthy hair follicle. If it's dividing, it gets killed. Targeted therapies, on the other hand, are vastly more sophisticated.
How so?
They are the result of us mapping the human genome and understanding the exact molecular mutations of the tumor. Targeted therapies don't attack all fast-growing cells. They are engineered to attack a specific genetic target on the cancer cell.
Give me an example of how a targeted therapy actually works on a molecular level.
A great example involves tyrosine kinase inhibitors. Certain cancer cells have a mutated receptor on their surface that acts like a faulty switch stuck in the on position, constantly telling the cell to multiply.
Okay, the jammed gas pedal again.
Right. A targeted therapy drug is designed to act like a specific molecular key that fits into that exact receptor, blocking the signal. It unplugs the machine.
Wow.
And because healthy cells don't have that specific mutated receptor, the targeted therapy largely ignores them, drastically reducing the traditional collateral damage.
That is incredible precision. And what about immunotherapy? You mentioned earlier that cancer cells put the immune system to sleep with a fake ID.
Right. Immunotherapy is arguably the most exciting frontier in oncology right now. It doesn't actually kill the cancer cells directly.
Wait, really? It doesn't kill them?
No. Instead, it acts like a massive software update for the patient's own immune system. Let's use a specific class of immunotherapy called checkpoint inhibitors. We talked about how cancer cells express a protein often called PD-L1 that acts like a fake ID.
Yeah.
When the T cell approaches, the T cell's receptor reads the fake ID and the T cell powers down. A checkpoint inhibitor is a drug that binds to either the fake ID on the cancer cell or the receptor on the T cell, effectively blocking the interaction.
Oh. It's like putting a blindfold on the security guard so he can't see the fake ID anymore.
Better yet, it's like confiscating the fake ID entirely. Suddenly, the cloak of invisibility drops. The T cell looks at the cancer cell, recognizes it as a deadly mutation, and sounds the alarm.
That's amazing.
The patient's own natural immune system wakes up, swarms the tumor, and destroys it.
Now, I have to play devil's advocate here because if I'm a nursing student listening to this, I'm thinking, wait a minute. If targeted therapies and immunotherapies are so smart, so precise, and so effective, why are we still using highly toxic blunt instrument chemotherapy?
That's a very fair question.
Right. Like, why do I see care plans where patients are getting combination therapy, they are getting chemo, immunotherapy? Isn't the smart drug enough?
It's a brilliant question. And the answer comes down to the biological reality of tumor environments and the power of synergy. What we know from clinical practice is that large established tumors are often cold.
Cold. What does that mean?
They have created such a suppressive, walled-off microenvironment that immune cells can't even penetrate them. If you just give immunotherapy, the T cells might wake up, but they can't get inside the fortress to do their job.
So how does the chemo help the immunotherapy?
The chemotherapy acts as the heavy artillery. You administer the chemo to breach the fortress. It goes in, violently damages a portion of the cancer cells, and creates a highly inflammatory, chaotic environment full of dying cellular debris.
Making a mess of things.
Exactly. This massive cellular death turns the tumor from cold to hot. By weakening the tumor and causing it to spill its internal proteins, the chemo actually makes the cancer highly visible to the immune system.
Okay, I see where this is going.
Then you administer the immunotherapy. The immune system, newly updated and heavily stimulated by the inflammatory debris caused by the chemo, rushes into this vulnerable environment and delivers the final targeted death blow. The chemo breaches the walls, and the immunotherapy sends in the special ops.
Chemo breaches the walls, immunotherapy sends in the special ops. That completely demystifies why we torture patients with combination therapies. We need both mechanisms.
Exactly. But as nurses, we are the ones standing at the bedside, managing the brutal fallout from these physiological wars.
Which is a huge part of the job.
So let's zoom in on these specific toxicities, starting with radiation. We need to dissect radiation bedside realities because your critical nursing interventions change drastically depending on whether the radiation is coming from an external machine or a radioactive isotope placed inside the patient.
Let's start with external beam radiation. The patient goes down to the radiation oncology suite, lies perfectly still on a table, and a linear accelerator aims high-energy X-rays at the specific tumor site. What is the core pathophysiology here, and what does the bedside nurse need to anticipate?
With external radiation, the most important mechanical concept to grasp is that the radiation beam has to physically pass through the patient's skin and healthy tissue to reach the tumor deep inside.
It's traveling through healthy tissue.
Right. As those high-energy waves pass through, they damage the rapidly dividing epithelial cells of the skin. The patient is going to develop a condition called radiation dermatitis.
Which is brutal.
It often looks and feels like an incredibly severe, blistering sunburn. The skin becomes erythematous red and inflamed dry, incredibly sensitive, and in severe cases, it could break down into open weeping wounds called wet desquamation.
So our primary nursing goal is aggressive skin preservation. What does that actually look like in our daily care?
It means our interventions are focused on removing absolutely any source of friction, extreme temperature, or chemical irritation. We teach the patient to wear only soft, loose-fitting, breathable cotton clothing over the irradiated area.
Right, nothing tight.
If they are receiving radiation to the chest, no tight bras, no underwires. We strictly instruct them to avoid extreme temperatures. No ice packs for the pain, and absolutely no heating pads.
Why no heating pads?
Because the radiation alters the skin's sensory perception, meaning the patient could easily suffer a severe thermal burn from a heating pad without even realizing it's too hot.
Wow, that's a huge safety risk. And what about hygiene and topical creams? Because human instinct, when you have a terrible sunburn, is to slather it in cooling lotions or aloe vera.
This is a major area for patient education. They can gently wash the area with lukewarm water and a mild unscented soap, but they must only pat it dry with a soft towel, never ever rub or scrub.
Pat, don't rub. Got it.
But regarding lotions, they must avoid all unapproved lotions, ointments, powders, perfumes, or deodorants on the radiated skin.
Why are over-the-counter products so dangerous?
Many commercial skin products contain heavy metals like zinc or aluminum in deodorants or various alcohols.
Wait, aluminum?
Yeah. If a patient applies a lotion with microscopic metals in it and then goes under the radiation beam, those metal particles will literally scatter the radiation beam on the surface of the skin.
Oh my gosh.
Yeah, it drastically magnifies the burn and potentially alters the dose reaching the actual tumor. They must only use specific approved creams like aqueous creams or specialized calendula ointments prescribed by their radiation oncologist.
It makes total sense when you understand the physics.
And one last critical point for external radiation. Once the machine turns off, the radiation is gone. The patient's not radioactive. They pose zero risk to you, to pregnant women, or to their children. They're perfectly safe to hug.
That is a very comforting fact for families. But that brings us to the other modality, where the safety rules invert entirely. Internal radiation, also known as brachytherapy.
Brachytherapy is a highly targeted form of local treatment, where a radioactive isotope, often shaped like tiny seeds, ribbons, or pellets, is physically implanted directly inside the body.
Right into the tumor, basically.
Right into or immediately adjacent to the tumor. We see this commonly utilized for prostate cancer, cervical cancer, or severe oral cancers. Because the radioactive source is physically residing inside the patient themselves actually emits a low dose of radiation out into the room while the implant is actively in place.
Okay, I have to throw a classic nightmare bedside scenario at you.
Let's hear it.
It's one that strikes fear into the heart of every nursing student. You are assigned a patient who has a temporary radioactive pellet implanted in their mouth to treat an oral carcinoma. You walk into the room to perform your morning assessment, and you see that the implant has become dislodged.
Oh boy.
The radioactive pellet is sitting right there on the linoleum floor. What is the very first thing you do? Because my immediate compassionate human instinct is to bend down, grab it, and put it back to save their expensive treatment.
You must let your clinical training violently override your human instinct.
Right.
If you reach down and pick up a radioactive source with your bare or even gloved hands, you are directly exposing your tissues to a concentrated, unshielded dose of radiation. This can cause severe, localized tissue necrosis to your fingers, not to mention the systemic exposure risk.
So no picking it up.
No. The strict clinical protocol for brachytherapy dislodgement is governed by the principles of ALERA as low as reasonably achievable. Your primary duty in that moment is your own occupational safety.
Okay, so step 1 is freeze. Do not touch it. Then what?
Step 2 relies on the concept of distance. Every patient receiving temporary brachytherapy will have a specific radiation emergency kit kept continuously in their room. You go to that kit and retrieve the long-handled forceps.
Tongs, basically.
Right? You use those forceps to carefully pick up the radioactive pellet. The length of the forceps provides a crucial few feet of distance, and according to the inverse square law of physics, doubling your distance from a radioactive source drops your exposure by a factor of 4. Distance is your best friend.
So you have it in the forceps.
Step 3 relies on shielding. You immediately place the pellet into a specialized lead-lined container, often called a lead pig, which is also kept right there in the room.
A lead pig?
That's what we call it. Lead is incredibly dense and provides vital shielding, stopping the radiation from penetrating out into the room. Only after the pellet is safely secured inside the lead container do you proceed to step 4.
Leaving the room to minimize your time of exposure, and immediately calling the radiation safety officer, nuclear medicine, and the attending physician. Time, distance, and shielding. That is how you handle the hazard.
That sequence makes total sense when you understand the physics behind it. We use the forceps for distance, the lead pig for shielding, and we minimize our time near it. And we never, ever touch it. Okay, the nightmare scenario is solved.
It is a high-stress event, but when you know the protocol and the underlying why, panic is replaced by precise action.
So we've exhaustively covered the localized attacks. Now we have to transition to the heavy hitter. The treatment modality that causes the most famous, systemic, and devastating side effects we manage as bedside nurses, traditional chemotherapy.
While radiation is a sniper rifle, chemotherapy is carpet bombing.
Exactly.
It is introduced directly into the vascular system and travels everywhere blood flows. And the reason it causes such catastrophic, widespread havoc comes back to its core mechanism of action on the cellular level. Chemotherapy drugs are designed to interfere with the cell cycle. Meaning what, in plain English?
In plain English, they hunt down and destroy fast-growing cells.
Because the defining characteristic of a cancer cell is rapid, uncontrolled division.
Exactly. But here is the fatal biological flaw of traditional cytotoxic chemotherapy. It is completely blind.
It doesn't know what it's hitting.
It cannot differentiate between a rogue, fast-growing adenocarcinoma cell and a perfectly healthy, normal, fast-growing cell. If a cell is actively moving through the phases of division, the chemotherapy enters it and destroys its DNA or structural proteins.
Which means we need to ask ourselves, what are the normal, fast-growing, rapidly dividing cells in the healthy human body? Because wherever those are, that is where the collateral damage will be most severe.
Right. There are 3 primary areas of rapid cellular turnover in a healthy human. First, the hair follicles, which are constantly growing, which explains why patients experience alopecia.
Hair loss, right.
Second, the entire epithelial lining of the gastrointestinal tract, from the mouth all the way down to the rectum, which is why patients suffer horrific mucositis, nausea, and diarrhea.
Ouch.
And third, and arguably the most critical for the bedside nurse's moment-to-moment clinical judgment, is the bone marrow.
The bone marrow hit. This is where a nurse's vigilance truly stands between life and death. Let's really unpack the pathophysiology here. I like to conceptualize the bone marrow as a massive, high-speed cellular factory.
It's the perfect analogy. The bone marrow, specifically the red marrow inside your flat bones and the ends of long bones, is the factory responsible for hematopoiesis, the production of all your blood cells.
It's busy in there.
It operates at a blistering pace, churning out billions of red blood cells, white blood cells, and platelets every single day to replace the mature ones circulating in your blood that naturally age and die off.
So when the chemotherapy enters the bloodstream, it circulates into the bones, sees this highly active, rapidly dividing factory, and attacks it. It essentially shuts the factory's production lines down.
It's temporary, but the assembly lines grind to a halt. Exactly. The clinical term for this factory shutdown is myelosuppression or bone marrow suppression. And because all 3 main production lines are down, it leads to a deadly triad of deficiencies known as pancytopenia.
Break that word down for us.
Pan meaning all, cyto meaning cell, and penia meaning lack of. The nurse's job is to fiercely protect the city, the patient's body, while the factory is offline and no new supplies are being shipped out.
Let's break down each of those three bloodlines, explain the biological half-life, and apply the bedside logic. Let's start with anemia, the drop in red blood cells.
Red blood cells, or erythrocytes, are the cargo ships of the vascular system. They are packed with hemoglobin and carry oxygen from the lungs to every tissue in the body.
Right.
Now, red blood cells actually have a fairly long lifespan in the blood, about 120 days. So the anemia doesn't happen the day after chemo. It takes a little time for the circulating supply to dwindle while the factory is shut down.
But when it does hit,
the patient becomes profoundly anemic. Without adequate oxygen reaching the tissues at a cellular level, the patient experiences crushing, debilitating fatigue and weakness. They will be dyspneic or short of breath with incredibly minimal exertion.
even just walking to the bathroom.
Exactly. They will look pale, and you will notice their heart rate elevating tachycardia as the heart desperately tries to pump the few remaining cargo ships faster to meet the body's oxygen demands.
So what is the nursing action? We can't just document patient feels tired and tell them to tough it out.
No, we have to actively and strategically manage their energy reserves. The critical bedside action is clustering your nursing care.
Clustering care.
You do not go into the room at 0800 to take vitals, OG 830 to administer medications, ZUON 900 to draw blood, and 0930 to do a bed bath. Every interruption costs them precious oxygen.
Yeah, that's exhausting for them.
You cluster your care so you accomplish multiple tasks at once, affording the patient prolonged, uninterrupted periods of vital rest. You prioritize. Maybe the full linen change can wait if they are severely hypoxic.
Definitely.
You strictly assist them with ambulation because that weakness makes them a massive fall risk. And if their oxygen saturation drops below baseline, you provide supplemental oxygen to maximize the carrying capacity of the red blood cells they do have left.
Okay, that is the red blood cell line. Next up in the pancytopenia triad, thrombocytopenia. This is the crash in platelets.
Platelets, or thrombocytes, are the body's microscopic mechanics. They have a shorter lifespan, about 7 to 10 days.
So this hits faster.
Much faster.
Yeah.
When you get a cut or a damaged blood vessel, platelets immediately rush to the scene, stick to the exposed collagen, and clump together to form a mechanical plug that stops the bleeding.
Right.
When the chemo destroys the megakaryocytes in the marrow that produce platelets, the patient loses their ability to clot. Severe thrombocytopenia turns minor traumas into massive hemorrhage risks.
This is where we implement strict bleeding precautions. What does that actually look like in our daily interactions with the patient?
Bleeding precautions require hypervigilance to eliminate any source of physical trauma, internal or external. For oral care, we abandon standard toothbrushes entirely and use ultra-soft bristle brushes or gentle sponge swabs because normal brushing will cause their friable gums to hemorrhage.
What about shaving?
We instruct the patient to only use electric razors, never street blades.
Right.
We rigorously avoid invasive procedures, absolutely no intramuscular injections, no rectal temperatures, no suppositories, and we avoid inserting Foley catheters unless critically necessary.
Because inserting it could cause internal bleeding.
Exactly. We ensure the room is free of clutter to prevent bumps or falls, and critically, we assess constantly for occult or hidden bleeding. We check their urine and stool for blood, and we examine their skin for petechia.
What are petechia exactly?
They're tiny, pinpoint red or purple dots that indicate capillaries are spontaneously microhemorrhaging under the skin due to lack of platelets.
You literally become a detective looking for leaks. And that brings us to the third and frankly the most rapidly lethal part of the triad, neutropenia, the catastrophic drop in white blood cells, specifically neutrophils.
Neutrophils are the frontline kamikaze soldiers of the innate immune system. They're the immediate first responders to any bacterial invasion.
But there's a catch with their lifespan, right?
Here is the biological catch that makes neutropenia so dangerous. Neutrophils have an incredibly short lifespan, sometimes only living for a matter of hours to a few days.
Oh, wow. Hours.
Yeah. The body relies on the bone marrow factory to constantly, continuously churn out new ones. When the chemo halts production, the neutrophil count plummets off a cliff almost immediately. Severe neutropenia strips the patient of their primary defense against infection.
And without those soldiers, a minor infection like a scrape or natural gut flora crossing into the bloodstream can progress to overwhelming fatal sepsis in a matter of hours.
Exactly. This is why neutropenic precautions are the strictest protocols in the hospital. The nursing action here is paramount. Meticulous hand hygiene is the single most important intervention.
Everyone washes their hands.
Everyone who enters that room must scrub their hands.
Mm-hmm.
The patient is often placed in a positive pressure isolation room, so clean air flows out into the hallway, preventing contaminated hallway air from drifting in. We ban anything that could harbor environmental bacteria or fungal spores.
Like what?
Absolutely no fresh flowers, no potted plants with dirt, no unwashed fresh fruits or raw vegetables.
But the most critical piece of monitoring here is the thermometer, right? Because they don't show normal signs of infection.
This is a vital piece of clinical logic for new nurses. Normal signs of infection, pus, swelling, intense redness at a wound site are all created by white blood cells rushing to the area and dying in battle.
Oh, right. No white blood cells, no pus.
If the patient has no white blood cells, they cannot mount a normal inflammatory response. They won't have pus. The only clinical sign of a life-threatening infection might be a fever.
And what's the threshold?
For a neutropenic patient, a single temperature reading of 100.4 degrees Fahrenheit or 38 degrees Celsius is a full-blown medical emergency.
A literal emergency.
If they spike that fever, you do not give Tylenol and wait. You immediately draw blood cultures to identify the pathogen, and you must have broad-spectrum IV antibiotics hanging and infusing within 60 minutes. Time is tissue, and time is life.
The intensity of managing the bone marrow hit is truly where nursing vigilance shines. But as we established earlier, the bone marrow is not the only rapidly dividing tissue that chemotherapy carpet bombs.
Nope, unfortunately not.
That rapid cell turnover is also happening in the other major casualty zone, the gastrointestinal tract. Let's explore the GI havoc, from the mouth all the way to the bottom.
The epithelial cells lining the entire digestive tract have an incredibly rapid turnover rate, normally replacing themselves every 3 to 5 days to deal with the harsh acidic environment of digestion.
So they get wiped out too.
When chemo halts that cellular division, the mucosal lining physically breaks down. It sloughs off, leaving raw, unprotected tissue. This leads to severe cascading side effects that drastically impact the patient's nutritional status, fluid balance, and overall will to endure treatment.
Yes, miserable.
The two most prominent issues we manage are profound nausea and severe stomatitis.
Let's tackle the nausea and resulting malnutrition first. Cancer patients are infamous for experiencing horrific, intractable nausea. And it's not just a stomachache. What is actually causing it?
The nausea is multifactorial. First, you have the physical damage. As the chemo breaks down the stomach and intestinal lining, the damaged cells release massive amounts of serotonin.
Serotonin, like the brain chemical.
Yep. This excess serotonin binds to vagus nerve receptors in the gut, sending a distress signal directly to the brain. Second, the chemotherapy drugs themselves circulate in the blood and directly cross the blood-brain barrier to stimulate the chemoreceptor trigger zone, or CTZ, located in the medulla oblongata.
The brain literally tastes the chemo.
Exactly. The brain detects these toxic chemicals and triggers the vomiting reflex to try and purge the poison.
Knowing that mechanism, what is our proactive bedside action?
Proactive is the absolute key word. The biggest, most amateur mistake a nurse can make is waiting for the chemotherapy patient to hit the call light and say, "I feel nauseous," or waiting for them to actively vomit before administering medication.
Because by then it's too late.
Once that intense neurological and gastric cycle of emesis begins, it is incredibly difficult to break. The gold standard bedside action is to administer a powerful antiemetic, such as a 5-HT3 receptor antagonist like ondansetron, commonly known as Zofran, at least 30 to 60 minutes before the chemotherapy infusion even begins.
Pre-medicate them.
You want those serotonin receptors in the gut and the CTZ in the brain completely blocked and shielded before the toxic chemo ever hits their system, and you maintain that scheduled antiemetic regimen around the clock for days afterward.
Because if they are violently nauseous and everything tastes like metallic cardboard, they stop eating and drinking entirely. Which circles right back to our early discussion about the tumor hijacking the blood supply and causing cachexia.
It creates a devastating, vicious cycle. The cancer is increasing their metabolic demand and stealing nutrients, while the toxic treatment has completely destroyed their ability to take in or absorb new nutrients.
It is a recipe for severe malnutrition and dehydration.
It is. As nurses, we intervene by encouraging small, frequent, high-calorie and high-protein meals rather than 3 large plates they can't stomach. We suggest serving food cold or at room temperature because hot foods release stronger aromas that can trigger the hypersensitive olfactory nausea reflex.
Oh, that makes sense. Smells trigger nausea.
And pharmacologically, we might collaborate with the provider to utilize medications like magistral acetate, which acts as a powerful synthetic appetite stimulant to help combat that profound anorexia.
Now let's talk about the other reason they can't eat, stomatitis or mucositis. What is the pathology here?
Stomatitis is the severe inflammation and ulceration of the oral mucous membranes. Just as the stomach lining slows off, the protective lining of the mouth, throat, and esophagus breaks down.
Oh, that sounds awful.
It creates massive, raw, bleeding sores throughout the oral cavity. It is agonizingly painful. Patients describe it as feeling like they are swallowing broken glass. They can't eat, they can't swallow their essential pills, and sometimes the pain is so severe they can barely speak.
I remember a nursing student asking me during clinicals once, if their mouth is full of open sores, can't we just have them vigorously swish with regular mouthwash to keep it clean and prevent an infection?
Oh, no.
And I almost jumped out of my shoes. I had to use a visceral analogy to stop them. I told them, having a patient with stomatitis use commercial mouthwash is exactly like taking a bottle of rubbing alcohol and pouring it directly onto a severe, blistering sunburn.
That is a brutally accurate, perfect analogy. Standard over-the-counter commercial mouthwashes like Listerine contain incredibly high concentrations of alcohol and other harsh astringents.
It would be agonizing.
If you introduce that to an oral cavity full of exposed nerve endings and ulcerated tissue, the pain would send the patient through the ceiling. Furthermore, the alcohol would severely dry out and chemically burn the already compromised mucosal tissue, delaying healing and increasing the risk of necrosis.
So understanding that, what is the actual evidence-based nursing action for oral care?
We implement meticulous, incredibly gentle oral hygiene protocols. We have them use ultra-soft toothbrushes, or if they're severely thrombocytopenic and bleeding, we switch entirely to soft sponge swabs.
And what do they rinse with?
We instruct them to rinse their mouth frequently, every few hours, with plain, sterile, normal saline, or a gentle mixture of salt and baking soda in warm water. The baking soda helps gently debride the tissue and neutralizes the acidic pH of the mouth, creating an environment conducive to healing.
So much better. And what about the pain?
To manage the severe acute pain so they can actually eat, we provide a medication like viscous lidocaine.
Let's clarify that term. Viscous meaning thick and sticky, like syrup.
Exactly. It's a thick, gel-like local anesthetic. The patient takes a small amount, swishes it around their mouth, and spits it out. Because that is viscous, it physically adheres to and coats the raw sores, numbing the exposed nerve endings.
Oh, that's smart.
We strategically have them do this swish and spit right before mealtime, so they have a 30-minute window of numbness where they can actually tolerate swallowing some high-calorie nutritional shakes or soft foods.
Okay, we have talked extensively about how toxic these systemic chemotherapy agents are to the cancer and the immense collateral damage they inflict on the patient's body.
Yep, a lot.
But we have to pivot to something equally critical that is often overlooked: hazardous duty. We need to talk about safe handling protocols because these drugs are highly toxic to the nurse, to the pharmacy techs, and to the patient's family members at home.
It's a huge safety issue.
This is especially urgent now as oncology shifts toward more outpatient models where patients are sent home with continuous IV chemo pumps or prescribed oral chemotherapy regimens.
This is an absolutely critical area of occupational safety and patient education. We have to treat chemotherapy agents with the exact same respect we would treat a hazardous chemical spill in a laboratory.
Seriously.
When a patient receives chemotherapy, the drug doesn't just vaporize inside them. It undergoes hepatic metabolism and renal clearance, and then it is excreted from the body.
And how long does that take?
The fundamental rule of thumb, supported by international oncology nursing standards, is that hazardous traces of the chemotherapy drugs and their toxic metabolites remain in the patient's system and are actively excreted in their bodily waste for approximately 48 hours after the administration ends.
And when we say bodily waste, we mean everything, right?
Every single bodily fluid. Urine, stool, emesis, saliva, sweat, and even vaginal fluids and semen. For a full 48 hours, those fluids must be clinically treated as if they are contaminated with toxic, DNA-altering hazardous drugs.
So what are the specific actionable safety rules we must drill into our patients and their families for home care? Let's start with the bathroom, since that's where the most excretion happens.
In the bathroom, the primary risk is aerosolization of the toxic urine or stool. When a toilet flushes, it creates an invisible plume of microscopic droplets.
The toilet plume.
Yeah. Therefore, we teach that both men and women must sit down on the toilet to urinate to physically prevent splashing. After they are finished, before they touch the flush handle, they must close the toilet lid completely. and then they must flush twice.
Double flush with the lid down.
The double flush, combined with a closed lid, ensures all hazardous waste is cleared through the plumbing without sending a toxic microscopic spray into the air for the next family member to inhale.
And what if a caregiver or spouse needs to assist the patient to the bathroom, or empty a bedside commode, or clean up vomit if the antiemetics fail?
The caregiver must rigorously protect their own skin and mucous membranes. They must don disposable nitrile gloves. And it is vital to specify nitrile, not standard latex.
Why not latex?
Many chemotherapy agents can actually permeate latex on a molecular level over time. They must wear these nitrile gloves whenever handling any bodily waste, whenever emptying containers, or even when touching the patient's oral chemotherapy pills. You never, ever touch a chemo pill with your bare hand.
And speaking of oral chemotherapy, we must explicitly warn our patients. Never crush, break, split, or chew oral chemotherapy pills.
Never.
What is the mechanical danger of crushing a pill? Patients crush their blood pressure meds all the time to make them easier to swallow.
Because the moment you crush a cytotoxic pill, you destroy its protective coating and create a fine, hazardous chemical dust.
And then it's in the air?
Exactly. The patient or the spouse preparing the medication can easily inhale that dust into their lungs, or it can settle on their skin and absorb directly into their bloodstream. Oral chemo pills are engineered to dissolve safely in the acidic environment of the stomach, and they must be swallowed entirely whole.
What about laundry? If the patient is dealing with cancer-related fatigue and night sweats, and they heavily soil their sheets, or if they accidentally get urine on their clothing.
Chemo-soiled laundry must be handled with those nitrile gloves. It must never be thrown into the hamper with the rest of the family's clothes. It must be washed completely separately.
Okay, separate loads.
And the protocol is to wash it twice, in the hottest water setting possible, using regular heavy-duty detergent to ensure all chemical residue is broken down and flushed away.
Okay, here is a high-stakes scenario that requires quick thinking. A lot of patients leave the clinic with a continuous 5FU chemo infusion pump connected directly to their portacath.
Right.
What happens if that IV tubing snags on a doorknob and leaks on the carpet, or if they drop a bottle of oral chemo pills and they shatter on the kitchen floor?
Every single patient who is sent home with hazardous drugs is provided with a specialized, bright yellow home spill kit, and the nurse must educate them on exactly how to deploy it.
So what's the first step?
If there is a spill or a leak, the immediate first step is to stop the source clamp, the IV tubing, or power off the pump. Then the caregiver opens the spill kit. It contains 2 pairs of thick nitrile gloves. They double glove.
Double gloves, got it.
They use the highly absorbent paper towels or spill pads provided in the kit to gently lay over and soak up the spill. They should never wipe or scrub, which just spreads the chemical. They clean the area with dish soap and water.
And what happens to the towels?
Critically, all of those contaminated materials, the pads, the double gloves, the broken pill fragments, must be placed into the special, heavy-duty, puncture-proof plastic bags provided in the kit. They tie it off, seal it tightly, and return it to the oncology clinic for proper incineration and hazardous waste disposal. It never, ever goes in the municipal household trash.
And what if, despite all these precautions, the chemo actually splashes directly onto the caregiver's bare skin during a leak?
If direct skin contact occurs, they must immediately wash the exposed area with copious amounts of soap and water for a full 5 to 15 minutes.
That's a long time.
Not just a quick rinse under the tap, a prolonged, continuous wash to manually remove the chemical before it can permeate the epidermal layers and enter the bloodstream. If it splashes into their eyes, they must flush their eyes continuously with water for 15 minutes and go immediately to the emergency room.
Hearing these intense, highly regulated home precautions really validates what we do at the bedside in the hospital. It completely explains the why behind our PPE.
It really does.
When we go into room 412 to hang a new IV bag of chemotherapy, we aren't just wearing standard gloves. We are wearing that thick, impermeable gown, the face shield, and 2 pairs of specialized, extra-thick chemotherapy gloves that pull up over the cuffs of the gown. We are aggressively protecting ourselves from cumulative, microscopic occupational exposure.
Exactly. It's not just a burdensome hospital policy designed to slow you down. It is rigorous, evidence-based practice designed to prevent oncology nurses from absorbing systemic toxins that could subtly mutate their own DNA over the course of a 20-year career.
All right, we have covered the cellular science, the staging, the violent treatments, the physical side effects, and the hazardous safety protocols. But as we move toward the end of our shift today, we have to talk about the human element.
We really do.
We have spent an hour focused intensely on the physical biology of the body, but cancer is a holistic, devastating disease. It attacks a patient's core identity, their mental health, their family dynamics, and their vision of the future. We cannot ignore the psychosocial aspects of care.
We absolutely cannot. In many ways, the psychological trauma and the invisible side effects of cancer are just as debilitating as the physical vomiting or the neutropenia.
Yeah.
And as a bedside nurse, you are often the only person spending hours upon hours with the patient, holding their hand in the quiet moments after the oncologist has delivered bad news and left the room. Let's start with body image, specifically alopecia or hair loss.
Hair loss is such a visceral public sign of illness. For many patients, it is the most emotionally traumatic part of the entire treatment process because it strips away their privacy. They can no longer hide their diagnosis from their coworkers, their neighbors, or the person at the grocery store.
It is a profound, forced loss of identity. And the psychological best practices tell us that we need to be incredibly proactive with anticipatory guidance.
What does that look like?
We do not wait for the patient to wake up, look at their pillow, and see their hair falling out in massive clumps, which is an incredibly traumatizing, out-of-control experience. We talk about it early, before the chemo starts. We encourage patients to take control.
How so?
We suggest they cut their hair short early on, go shopping for a wig, or pick out beautiful scarves and hats before the cytotoxic drugs start attacking the hair follicles.
What is the underlying psychology behind doing all of this before the hair actually falls out?
It provides the patient with a crucial, empowering sense of control in a medical situation where they feel entirely powerless and at the mercy of the disease.
That makes sense.
If they choose to shave their head on their own terms, surrounded by family, they are making an active choice, rather than sitting passively and having the cancer slowly degrade their appearance. Furthermore, from a practical standpoint, if they visit a wig specialist while they still have their natural hair, the specialist can match their hair color, texture, and style much more accurately, which helps preserve their self-image when they look in the mirror.
That is such a compassionate, psychologically sound intervention. Now, what about the invisible burdens that no one else can see? I'm talking about pain and profound fatigue. We mentioned fatigue earlier in relation to anemia, but cancer-related fatigue is entirely different than just being tired after a 12-hour shift, isn't it?
It is fundamentally different. Cancer-related fatigue is a profound, paralyzing cellular depletion.
Paralyzing.
It is driven by cytokines, inflammatory proteins released by the body's immune system as fights the tumor, coupled with the massive ATP energy drain of the tumor itself, the anemia, and the toxic burden of the treatments. It cannot be fixed by taking a nap.
So what can we do?
We have to validate this reality for the patient. We have to tell them they aren't crazy for feeling exhausted after simply taking a shower. We teach them energy conservation techniques, identifying the time of day they have the most energy and doing their most important tasks then.
Budgeting their energy.
Exactly. But we also encourage light, programmed physical activity, like a short daily walk, because paradoxically, prolonged bed rest actually exacerbates cancer-related fatigue by causing rapid muscle deconditioning.
And regarding pain, we are guided by the WHO pain ladder, right? Moving systematically from NSAIDs to mild opioids and eventually to strong opioid narcotics around the clock for severe bone or neuropathic pain.
Yes, aggressive and appropriate pharmacological management is key, but we also integrate non-pharmacological methods, massage therapy, guided imagery, relaxation techniques, and the application of heat or cold, but only when safe.
Right.
Remember, if they're receiving radiation, those skin precautions we discussed earlier absolutely forbid heating pads on the irradiated area.
Which brings me to a really important conceptual pushback question. When we talk about managing severe, intractable pain and crushing fatigue, and we use the term palliative care, I know so many people, patients, families, and even veteran nurses who hear the word palliative and immediately think, okay, the team is giving up, the patient is actively dying, and we are just moving them to hospice to wait for the end. Is that accurate?
No. That is one of the most persistent, common, and damaging misconceptions in all of healthcare. Palliative care is not synonymous with end-of-life hospice care.
Okay, let's clear this up.
The expert consensus and the latest oncological guidelines are explicitly clear on this. Palliative care should be integrated into the treatment plan early, ideally within 8 weeks of any advanced cancer diagnosis.
Wait, so a patient can actively receive palliative care while they are simultaneously receiving aggressive curative chemotherapy?
Absolutely. Palliative care is a specialized medical discipline focused entirely on providing relief from the symptoms and the immense stress of a serious illness. The sole goal is to improve the quality of life for both the patient and the family.
So who provides it?
A palliative care team consists of specialized doctors, nurses, social workers, and chaplains. They step in to expertly manage the excruciating bone pain, the intractable nausea we talked about, and the psychological terror. They help clarify complex treatment goals when the patient is overwhelmed, and they facilitate difficult family communications.
It's extra support.
By managing these crippling symptoms early and aggressively, palliative care actually strengthens the patient, helping them tolerate their harsh curative treatments better and for a longer period of time. Hospice is a specific separate type of palliative care reserved for the very end of life when curative treatment has been completely halted.
Got it.
But palliative care itself is fundamentally about living as well and as comfortably as possible while you are actively fighting the disease.
That reframe changes the entire landscape. It takes the dread and the fear out of the word palliative and turns it into a powerful, proactive tool for the bedside nurse to advocate for. If your patient is suffering, you advocate for a palliative consult to help them fight.
It is arguably one of the most vital, life-enhancing referrals a nurse can initiate.
Wow. We have covered an immense, incredible amount of clinical ground today. Let's do a quick, high-level summary of the biological journey we just took.
Yeah.
We started by understanding the rogue cell, how the jammed oncogene gas pedal and the broken tumor suppressor brakes lead to a manipulative, immortal cell that forces angiogenesis to hog nutrients, and how that translates directly to the bedside red flag of unexplained weight loss.
Then we decoded the T&M staging system, visualizing how the tumor grows in size, unvelcros itself to hit the lymphatic highway via the nodes, and eventually metastasizes to distant organs.
Right. And then we analyzed the arsenal. We contrasted the precision sniper fire of local radiation and targeted therapies with the systemic carpet-bombing nature of traditional chemotherapy, and we explored how immunotherapy acts like a security update to rip up the cancer's fake ID.
We focused relentlessly on protecting the patient from the fallout of those treatments. We discussed the strict, friction-free skin care required for radiation dermatitis and the Air protocol of time, distance, and shielding for dislodged radioactive implants.
We dove deep into the bone marrow factory shutdown, managing the hypoxia of anemia, the severe bleeding risk of thrombocytopenia, and the critical life-threatening infection risk of neutropenia, where a 100.4 fever is a literal siren.
We mapped out the GI havoc, emphasizing the absolute necessity of proactive pre-chemo antiemetics and why using commercial alcohol mouthwash on stomatitis is like pouring acid on a burn.
And we spent crucial time detailing safe handling protocols, protecting the nurse and the family by understanding the 48-hour pharmacokinetic excretion rules, the double flush toilet protocol, and the exact steps for deploying a hazardous spill kit.
Finally, we brought it all back to the human being in the bed, giving patients psychological control over alopecia, differentiating cellular fatigue from normal tiredness, and completely reframing palliative care as an early, aggressive symptom management strategy, not a death sentence.
The overarching clinical takeaway we want every listener to absorb today is this. Oncology is undeniably complex. But when you truly understand the why and the how, when you know that chemo causes neutropenia because neutrophils have a short half-life and the marrow factory is down, your nursing interventions stop being arbitrary lists you memorize for the NCLEX.
Exactly. They transform into logical, intuitive, and ultimately life-saving actions.
You aren't just memorizing a rule that says no fresh flowers in room 412. You know why? Because that patient has 0 frontline soldiers to fight the microscopic fungal spores on those petals. That clinical logic is how you bridge the gap from being a student who passes tests to becoming an exceptional, observant bedside nurse.
I want to leave you with a final provocative thought about the future of our profession. For decades, the oncology nurse's role has been heavily focused on managing the catastrophic toxicity of blunt instrument chemotherapy, the bone marrow crashes, the severe nausea, the physical wasting.
Yeah.
But as medical science advances at breakneck speed, we are rapidly moving toward an era dominated by highly personalized genetic medicine.
Like those software updates for the immune system, the checkpoint inhibitors and CAR T-cell therapies?
Yes. As treatments become incredibly precise and rely on supercharging the patient's own immune system, the bedside nurse's primary challenge is going to fundamentally evolve.
In what way?
We will be transitioning from primarily managing immune suppression and toxicity to managing immune hyperactivation. We will be looking for entirely different bedside red flag signs that the patient's artificially upgraded immune system is suddenly overreacting and attacking healthy organs, causing rampant autoimmune inflammation.
That's a huge shift.
The foundational requirement for nursing vigilance remains exactly the same, But the weapons and the collateral damage of the battlefield are changing right before our eyes.
That is both a daunting challenge and an incredibly exciting evolution for the future of nursing. It means we can never stop learning, we can never stop asking why, and we must continually hone our critical thinking.
We have to.
And that is exactly what we are here to help you do. Thank you so much for joining us for this extensive conversation on the Super Nurse podcast. Please remember to go watch the highly visual comic book video version of this exact episode on YouTube. Hit that like button, subscribe to the channel, and leave us a comment about your biggest aha moment or connection today.
And be sure to visit supernurse.ai for amazing evidence-based tools and resources designed specifically to help you apply this pathophysiology directly to your clinical practice.
Until next time, keep asking why, keep connecting the dots at the bedside, and go become the super nurse you were born to be.